This is part 2 of cold-induced tissue injuries presentation. In this part of the presentation, we will cover the risk factors for developing frostbite, what are some prevention and management strategies, and a brief summary. Here are some of the risk factors for developing a frostbite. Low temperatures in combination with wind chill put you at risk. Wind chill increases the heat loss by convection. Duration of cold contact is important. Also, being at high altitude puts you at risk due to low temperatures and low oxygen levels and pressure at the high altitude. Also, remember, if you've been at high altitude for some time, you start to produce more red blood cells. You also might be a little bit more dehydrated, and that causes hyperviscosity. And remember, in frostbite, venous stasis is something that develops as well. The combination of the two can put you at a higher risk. There are also studies on genetic predisposition for development of frostbite. Wearing constricting, wet, or inappropriate clothing puts you at risk. Also, wet skin puts you at risk of developing frostbite, and that's because it increases heat loss through evaporation. Altered mental status can put you at risk. So, someone who has high altitude cerebral edema, or maybe someone who is drunk at altitude, is less likely to notice symptoms and signs of frostbite and seek shelter. Smoking and such comorbidities as diabetes, Raynaud's, arteritis, and atherosclerosis all put one at risk for development of cold-induced tissue injuries. Previous frostbite is a risk factor, and also is immobility. Movement promotes heat production and increases circulation, so being immobile is a risk factor. This chart shows you how fast one can develop frostbite depending on the ambient temperature and wind speed. I like this chart because it shows that it doesn't take much to get into trouble. In the purple section of the graph, it would only take 5 minutes of exposure to those temperatures and wind speeds to develop frostbite. In dark blue section, it would take 10 minutes. So if you were in negative 10 Fahrenheit weather with the wind of 25 miles per hour, which is pretty reasonable, it would take you only 10 minutes to develop frostbite if you did not have appropriate protection. Say you took off your glove to snap a cool photo and it flew off the ridge. You're now at great risk of getting frostbite. It really doesn't take much. So, what are some of the prevention strategies for development of frostbite? First of all, avoid temperatures below negative 15 Celsius and also high winds. Make sure you protect your skin from wind, cold, and moisture. It is important to have adequate core temperature, hydration, and nutrition, and also to minimize effects of drugs and medical conditions. Avoid constricting clothing, and also staying immobile for prolonged periods of time. Make sure to use supplemental oxygen once you are above 7,500 meters. That's around 26,000 feet. Also address frost nib and superficial frostbite early to avoid more devastating injury. Make sure you're performing cold checks, and that means periodically checking your feet and hands, especially if you notice any numbness. So, what is the treatment of frostbite in the field? If you find yourself greater than 2 hours from definitive care and there is no risk of refreezing the injury, you should be rewarming patients' frostbitten extremities. Number one, make sure you address hypothermia or any other serious trauma, like a pneumothorax or a severe brain injury. You also want to remove jewelry or other extraneous material from the body part that's affected. Rapid rewarming is achieved in water heated and maintained between 37 to 39 degrees Celsius until that tissue becomes soft and pliable. So in general, it takes about 30 minutes. You can allow spontaneous or passive thawing if rapid rewarming is not possible. You should also be administering ibuprofen, that's 12 mg per kg per day, divided twice daily, if you have that available. Other pain medications, possibly opiates, might be needed, as the process of thawing is quite painful. Make sure you're air drying the extremity after thawing it. You don't want to be rubbing it, as this can create more tissue injury. And definitely protected from refreezing or any other trauma. So you want to apply bulky and dry dressing to the area. Before you apply the dressing, if you have topical aloe vera cream or gel, um, apply that first. Afterwards, elevate the affected body part if possible. Give the patient systemic hydration, and definitely avoid ambulation on thawed lower extremity unless uh, it's only the distal toe that's affected. What is the in-hospital management of frostbite? First of all, you want to determine the perfusion injury and frostbitten extremity. For that, you should perform angiography, or more commonly, a bone technetium scan is performed. Uh, Tetanus should be updated in the patient with frostbite, and thrombolytics can be considered, especially if the patient presents within 24 hours of thawing and the injury is severe and extensive. Iloprost is another medication that's been studied and is helpful in treatment of frostbite. It's a prostacyclin analog and it's a vasodilator. Pentoxifylline also decreases blood viscosity, increases red blood cell flexibility. It is often used in peripheral vascular disease. Um, Other management to consider is sympathectomy and delayed amputation. Amputation should be performed after tissue is well demarcated. Antibiotics, heparin, and hyperbaric oxygen therapy are not recommended by current guidelines. This is an angiogram of the patient who received TPA or thrombolysis. On the top, you can see the angiogram before TPA was administered, and on the bottom, you can see increased perfusion to the fingers after TPA administration. So definitely consider thrombolysis when the patient presents within 24 hours of thawing. Above is the photo of our patient's frostbitten digits after rewarming at EverCR. Below is technetium scan of the hands after he received a thrombolysis in Kathmandu. As you can see, perfusion to his thumbs, right index finger, and most of the left index finger was restored. This allows for grasping motion, which is an important functional outcome for our patient. Here is a photo of our patient still in EverCR with oxygen as he was hypoxic and the bulky dressing on his hands after he was rewarmed. He's awaiting helicopter evacuation. And on the right, you can see a sketch for the amputation surgery planned 3 months after the injury. So this is a quick summary of our frostbite lecture. Remember, prevention is key. The extent of injury is difficult to determine initially, so assume there's a deeper injury than what you can visualize. Avoid refreezing as this worsens outcome. Initiate active rewarming if you are greater than 2 hours away from definitive care. And make sure you're protecting the frostbitten area. Apply aloe vera and give ibuprofen. Thrombolysis is now an option, so consider it if there is an extensive injury and you are within 24 hours of rewarming. This is just a reference slide for this lecture. Thank you.